Hello everyone. Yes, we are here for FMG mission to crack at least 150 questions from these sessions. Yes, these are must know MCQs. Must know MCQs. Yes, myself Dr. Sanjay Khatri, your pediatric educator. I try my level best to give you best of the must know MCQs. Yes, few we have discussed, few some other format, some are previous year question. With my experience, these are the top questions you need to revise at this particular time. So first thing about the NEET PG notes. Yes, valid 6th July. You can offer, see the price until 16th July. This is the subscription for you. So yeah, go for it. Go for it. NEET PG notes. Presenting NEET PG Vitals. All educator of Unacademy with their best experience created a video for you. You join and feel the difference. Feel the difference of content, questions, and of course, technology. Take NEET PG MD scholarship test. I always prefer you should do this type of test. Nothing to lose. You will gain something. See, assured scholarship to all who take the test. My friend, take the test and assess your performance amongst others. Now, straight come to FMG, the most important topics and question. Read the question, try to answer this. A child presented with impairment of vision, cherry red spot in eye, no hepatosplenomegaly. So only clue that child is having cherry red spot and no hepatosplenomegaly. All storage disease, whether it's a Gaucher, Fabry's, Niemann-Pick, Hunter, Hurler, von Greeke, all have hepatomegaly. Only one storage disease, no hepatosplenomegaly. And clue, cherry red spot in the eye. It is Tay-Sachs disease. Tay-Sachs disease. Very good. This question 4 times in last 2 years. Now, one thing more. It is due to deficiency of hexaminidase A. It is due to deficiency of hexaminidase A. One more question on Tay-Sachs disease. It has exaggerated startle reflex. No need to tell you what is startle reflex. Yes, with the noise, baby do like this. So Tay-Sachs disease, these all are the MCQ. Cherry red spot in the eye, neurodevelopmental regression, child is not able to make eye contact, child is not able to hold the neck. So these all with exaggerated startle reflex or no hepatosplenomegaly, it is Tay-Sachs. One exam, they ask which enzyme deficiency is there. Hexaminidase A. Question may come either enzyme deficiency or direct clinical. Answer this. Evergreen question for FMG. Answer. All are true about infantile hypertrophic pyloric stenosis. See what happened. This is stomach. Here it is pyloric stenosis. Now what is secreted here? HCl. So if child vomit, HCl come out, H ion come out, chloride come out. So there is hypochloremic metabolic alkalosis. Hypochloremic metabolic alkalosis. Number one. When child vomit, what is the classical feature? The vomiting is clinical feature projectile and non-bilious vomiting. Have you seen a patient of pyloric stenosis? They vomit like you will wonder. A 2 kg baby vomit, projectile vomiting. Vomit go far from the body, projectile vomiting. and it's non-bilious. Clinical feature. When you examine, what you examine? Peristaltic wave and lump. Where you palpate the lump? In epigastrium. What is the best time when you able to palpate the lump? Lump is palpable best after vomiting. Yes, yes, yes. You can also interact. Peristaltic wave move from left to right. What is the best time to look for peristaltic wave? After feeding. After feeding. This thing we should know. Now come to the question. Lump palpable after vomiting. Yes, when musculature is relaxed, you can palpate the lump. Hypochloremic metabolic alkalosis is a biochemical abnormality. Yes, it is more common in firstborn male child. Yes. Peristaltic wave move from right to left? Absolutely no. Absolutely no. It's move from left to right. And best time to see the peristaltic wave? After feeding. Two more MCQs. Vomiting is projectile and non-bilious. Two more MCQ. If mother is taking erythromycin during pregnancy, pyloric stenosis develop in the baby. Okay, and investigation of choice, USG abdomen. Very good, very good, very good. Nisar, DK, good. Pyloric stenosis, evergreen question for FMG exam. You find in some or another way. Sometimes you feel it's very simple. They ask which is true. Hypochloremic metabolic acidosis, hypochloremic metabolic alkalosis, hyperchloremic metabolic alkalosis, like that. Very easy. Sometimes this form, all are true except which of the following is right. Like pyloric stenosis. Tay-Sachs disease, pyloric stenosis. Must know questions. Answer. Last year FMG question. Question on resuscitation I will cover. No problem. DK question is there in this session itself on resuscitation. Child brought with the history of frothiness from mouth and respiratory distress on X-ray. Frothiness and respiratory distress. Child should not be the correct. It's a neonate. And X-ray. What X-ray show? This is nasogastric tube. It's not going. It's curl here. Yes, it is tracheoesophageal fistula. So child neonate presented with frothiness from mouth and respiratory distress. Tracheoesophageal fistula. Sometimes they ask what you will do. We will try to pass a nasogastric tube and take a X-ray. Okay, this is tracheoesophageal fistula. One thing I want to know from you, if this is the history, what present antenatal history of mother? Antenatal history in mother, what it suggests? Anybody? Neonate with this, then you ask one question from mother. Is there so? Is there mother have history of polyamhydrios? Why? Because upper end of esophagus is blunt. Lower end of esophagus is connected to trachea. When upper end is blunt, baby is not able to swallow amniotic fluid. So there is a history of, yes, very good, Yusuf, Sezal, there is a history of polyhydramnios. So sometimes we need to answer with all things in total. Frothiness, respiratory distress, mother is having polyhydramnios history, X-ray show this, it is tracheoesophageal fistula. Tracheoesophageal fistula. Type 3, very good, very good, very intelligent. This is type C, or type 3 is most common. Sometimes they give you picture, which is the most common. Sometimes they ask you upper end of esophagus blunt, lower end of esophagus blunt. Upper end is connected to trachea, lower end is blunt. So just remember, this is the commonest. Upper end is blunt, esophagus. This is trachea. Lower end of esophagus connected to trachea. This is commonest, type C. Commonest, type C. Answer this. Take your time. Slowly answer this question. You can't imagine an exam of pediatrics without breast milk. Which of the following statement is not correct? Our question is, which of the following statement is not correct? Human breast milk and cow's milk contain equal percent of water. Yes, both contain 88% of water. True. Human breast milk contain more carbohydrate as compared to cow's milk. Yes, human breast milk contain 6.5 to 7. Cow's milk contain 4.5 gram percent of carbohydrates. Okay, go for it. Human breast milk and cow's milk contain equal amount of fat, but one difference is there. Human breast milk contain equal amount of fat. Both have 3.5 fat, but it contain more polyunsaturated fatty acid. It contain more saturated fatty acid. Polyunsaturated fatty acid, which is good for brain growth. Breast milk is the best gift a mother can give to the baby. A mother can give to the baby. Polyunsaturated fatty acid, good for brain growth. Fat is equal, but human milk, non-comparable. Polyunsaturated fatty acid. So A is right, B is right, C is right. What is D? Human breast milk contain more protein as compared to cow's milk? Yes. No. Human breast milk contain 0.9 to 1.1 gram percent protein as compared to cow's milk, which contain 3.3 gram protein. Is it so? Yes. Human breast milk contain less protein, but it is good quality protein. More Y is to casein ratio as compared to cow's milk, which is poor in Y casein ratio. So it is not easily digestible, not absorbable. Human milk, although contain less protein, but easily digestible, easily absorbable. No loads on kidney, even in the preterm baby. So always remember this. Always remember this. Breast milk, calorie, both 70-70. Water, 88%. Fat, equal. 3.5 to 4, 3.5. But breast milk contain more polyunsaturated fatty acid. Cow's milk contains saturated fatty acid. It's a truth. Breast milk contain more carbohydrate as compared to cow's milk. So these 4 points you can easily remember. You can't remember breast milk composition when you are reading. Just in a fun, we remember in 2 minutes all the points of breast milk. See, protein 0.9 to 1.1. Cow's milk 3.3 to 3.5. Y casein ratio is 70:1 as compared to cow's milk. Y less, casein more. So breast milk contain less protein as compared to cow's milk, but good quality protein. Y casein ratio 70:30. Am I clear? Clear? Now few more things. We make every effort baby should take the mother's milk. Normal delivery, mother discharged next day morning, baby develop jaundice. No option, need to keep in the nursery. Phototherapy. So we advise mother, you at home, distance from nursery to home is 10 kilometer. She can't come every time to feed the baby. So express your milk in a container and send it once or twice in nursery. Sister, put the container name, baby of Sita, baby of Geeta, baby of Salma, like this. There are so many container in the nursery and baby will enjoy the expressed breast milk. Expressed breast milk contain at room temperature up to 6 hours. In refrigerator, 24 hour. Deep freeze, 3 months. Yeah, Rishi, good day. Breast milk, initial part of the milk. Suppose a feeding duration is 20 minutes. Initial 10 minutes feed is known as foremilk. Later part, hind milk. Now remember, foremilk is rich in protein. It satisfies thirst of the baby. Hind milk is rich in fat. It satisfies hunger of the baby. So sometime comes, all are true about breast milk except foremilk rich in fat. No, F नहीं है. Foremilk rich in protein. Hind milk rich in fat. So these all about breast milk and their MCQ. You should remember. Something more? Something more? Yes. Breast milk causes hemorrhagic disease of newborn. Babies on breastfeeding may cause hemorrhagic disease of newborn. Bleeding occur at puncture site, at site where you put the cannula, you take the sample, rare ICH. Hemorrhagic disease of newborn. Why? Because breast milk contain very little amount of vitamin K. That's why during resuscitation, we give vitamin K to everybody, every newborn at the time of birth. On the other hand, cow's milk protect against hemorrhagic disease of newborn. Why? Because cow's milk contain 4 times of vitamin K as compared to breast milk. How you diagnose hemorrhagic disease of newborn? Just do PT. If PT increase, it is early HDN. In late HDN, PT and APTT both increase. Breastfeed. This is about breast milk. Answer this. Again, I will call this evergreen question. Which of the biochemical marker used for antenatal screening of Down syndrome during first trimester? See, antenatal screening of Down syndrome. In today's era, everybody has 1 or 2 children. No one want their baby born with the Down syndrome. So what we can do? Down syndrome is the commonest chromosomal anomaly. The people who are doing genetic medicine, people who are doing antenatal sonographies, so they try to detect Down syndrome. Now, previously, we used to do screening for Down syndrome in female with age more than 35 or any female having previous baby with Down syndrome. But nowadays, even obstetrician prefer or sometimes patient herself prefer that doctor, I don't want any syndromic baby. You can do all the test. So yes, antenatal screening of Down syndrome, we have biochemical marker and with sonography. So what are the biochemical marker? What are the biochemical marker? Generally, we do in second trimester, 16 to 18 week. See, alpha fetoprotein increase, alpha fetoprotein decrease, estriol decrease, and SCG increase. This is known as triple test. If we add fourth marker in this, that is inhibin A, then it become quadruple test. Last to last year FMG, all are the antenatal screening marker for Down syndrome except D choice was inhibin B. It's not inhibin B, it's inhibin A. It's inhibin A. So remember, it's inhibin A during second trimester. Okay, somebody wants to know Down syndrome because previous baby is Down syndrome. So they don't want to continue pregnancy with a Down syndrome because first baby is already Down syndrome. They want to be doubly sure. Can we do it in first trimester? Yes, we can diagnose Down syndrome in first trimester by two biochemical marker. Decrease PAPPA, pregnancy associated placental protein A. It is decrease. And beta HCG increase. So during first trimester, what will be answer? PPA decrease, HCG increase. You find n number of question on antenatal screening of Down syndrome. All are true except they will put decrease alpha fetoprotein A, decrease estriol, increase HCG, increase PAPPA. Now they want to ask you which of the following is not correct. This is not correct. PAPPA not increase, it is decrease. It is decrease. So remember, PAPPA decrease, HCG increase. We can diagnose by these two biochemical marker Down syndrome even in first trimester. Clear? Clear? Answer this. Again, a common question on vaccine. I have seen this question in so many grand tests. Which one of the following statement is correct about intradermal fractional inactivated polio vaccine respect to intramuscular IPV? So we have one schedule, National Immunization Schedule, followed at all government hospital, PSC, all vaccines are free. And second schedule is Indian Academy of Pediatrics. What National Immunization Schedule say? Birth, 6 week, 10 week and 14 week. Birth, OPV, 0 dose. What IAP says? Birth, OPV, 0 dose. Clear? But 6, 10 and 14 week. National schedule says OPV1, OPV2, OPV3. What IAP says? Injectable polio 1, injectable polio 2, injectable polio vaccine 3. Clear? No problem in this. It was going for so many months. Then National Immunization Schedule, they recognize the importance of IPV also. So they want to include IPV in their schedule. So they include it. 6 week fractionated IPV, 14 week fractionated IPV. They continue oral polio, but they also include injectable polio. When they are already given OPV, so how can they give IPV? So they give 1/5 dose of IPV. It is 1/5 dose of IPV. Injectable polio dose is 0.5 ml. 0.5 ml, which we give IM. Fractionated IPV dose is 0.1 ml and it is given intradermally. So sometime question come, as per National Immunization Schedule, fractionated polio vaccine given at birth 6 week, birth 10th week, 6 week 10 week, 6 week 14 week. So answer would be 6 week 14 week. What is fractionated? It is 1/5 of IPV given intradermally. It is 1/5 of IPV given intradermally. Which schedule do you prefer? Being a pediatrician, I always prefer IAP schedule. IAP schedule because it cover all non-essential vaccine also, which give you full protection. National schedule, all government dispensary, it's free. But IAP contain chicken pox, MMR, those vaccines, influenza, typhoid, cholera, all vaccine included in IAP, but not in national immunization schedule. So IAP is a preferred schedule for any pediatrician. Okay. So there, fractionated IPV is 1/5 of IM dose of injectable polio vaccine, and it is given at 6th and 14th week of national immunization schedule. Clear? Again, a common question, last year question. Which vaccines are stored in top rank of main refrigerator compartment at temperature of 4 to 10 degrees centigrade? You should remember, this is again a evergreen question which never leave you. So this is freezer. This is first compartment. This is second compartment. This is third compartment. This is the door of the freezer. It's a rule, no vaccine should be kept at door. Freezer, you can put OPV. First compartment, you can put MMR, measles, and BCG. Third compartment, you put all diluents, normal saline and distilled water. Rest all vaccines in second compartment. Clear? So simple. So they are asking top rank. This is the top rank compartment. So what we can put here? We can put BCG, measles, MMR. So other than this, can anybody tell me what other vaccine you can put in the top rank? Top rank of refrigerator. Anybody? Any idea? These three evergreen. Yes, we can put these three. Other than this, it's difficult to remember sometime. DK, I will try to write on this side of the slide. No problem. But I want answer from you. First rank, you can put meningococcal, Japanese encephalitis, and yellow fever vaccine also. So this is the refrigerator. Top OPV. First compartment, BCG and measles. Base, diluent. Door, no vaccine. Then all other vaccine in middle. But top compartment, you can also put Michael Jackson fever, meningococcal, Japanese encephalitis, and yellow fever. This is my way of remembering. So cold chain, place measles, MMR, BCG, yellow fever, Japanese encephalitis, and meningococcal on top shelf. MMR, BCG, you all remember. Today remember Michael Jackson fever means yellow fever. MJY, top rank vaccine. All other vaccines in second compartment. Base for diluent. So clear, na? Clear? So yellow fever, MMR, BCG, meningococcal, Japanese encephalitis. Answer. Last to last year NEET PG question. ANM has to conduct vaccination camp in village. She received to open vial of MR and Penta. What should be done? Suppose this is vaccine vial. Which contain 10 dose. Now when she received MR and Penta vaccine, so 5 doses are given, but 5 is still remaining. 5 are given, but 5 is still remaining. She can use? No. There is a policy, specific policy. If this vaccine you open, don't use for next day. This vaccine you open, keep in the cold chain, can be used in the next camp. So what is open vial policy? Applicable to DPT, TT, hepatitis, OPV, IPV, Hib, pentavalent vaccine, pneumococcal conjugate vaccine. Means applicable to most of the vaccine, but we need to remember not applicable to. It's very simple. BCG and measles. BCG, measles or MMR you can say, other than Japanese encephalitis and rotavirus vaccine. So remember these. Open vial policy not applicable to BCG, MR, Japanese encephalitis and rotavirus vaccine. So ANM found open vial of Penta and MR. Penta she can use. MR discard. So use Penta and discard MR. Use Penta and discard MR. So simple, na? Try to remember the simplest thing. Try to remember the simplest thing. Which vaccine to be used, which vaccine can be discard. Clear? So vaccine, cold chain, open vial policy, fractionated polio. These are must know MCQs. Remember me if you got one of those in exam. Okay? My best wishes, blessing to all of you. Just this is an end moment. Final revision, or you can call final punch. Yes, be confident. Answer this. Parents of 6-month-old boy point out that he just cut his first tooth, wondering which teeth will come next. Answer this. You should know the normal dentition. Primary teeth are 20. Secondary, or we called permanent teeth, are 32. So how primary teeth erupt? What is their sequence? Which is the first teeth erupt? When total all 20 teeth erupted? When we use the word delayed dentition? So many MCQs. So see here. First teeth to erupt in an infant is lower central incisor. So first of all, central incisor. When? 6 to 8 months. Then comes lateral incisor. When? 8 to 10 months. Slowly. Then molar 1, 10 to 16 months. Then canine, 16 to 20 months. Then molar 2, 20 to 30 months. Clear? Now listen. See on the screen. This is central incisor. This is also central incisor. This is also central incisor. This is also central incisor. So one tooth represent 4 teeth. So see, central incisor, 6 to 8 months, number of teeth 4. Lateral incisor, 8 to 10 months, number of teeth 8. Then molar 1, 10 to 16 months, number of teeth 12. Then canine, 16 to 20 months, number of teeth become 16. Then molar 2, 20 to 30 months, number of teeth is 20. So all primary teeth 20 erupt by the age of 2.5 years. What is the meaning of 30 months? 2.5 years. See here. What is the sequence? First central incisor, 6 to 8 months. then lateral incisor 8 to 10 month, then first molar 10 to 16 month, then canine 16 to 20. Clear na? Dental age. This is the sequence. Which 3 year back FMG question, which is the first teeth to erupt in an infant? Lower central incisor. Sometime comes as a lower central incisor or sometime comes as a mandibular incisor. Choice. Remember, dental age. Must know MCQ for FMG exam. Must know MCQs. Clear. Answer this. FMG, my 3 year experience, not less than. They ask one word, they ask clinical question, they ask question based on the treatment also sometime. So they raise the level of FMG exam very high. A 2-year-old girl presented with hepatosplenomegaly, short stature, coarse facial look, large tongue, corneal clouding, recurrent upper respiratory infection, noisy breathing, persistent copious nasal discharge. What else you want? All points suggesting it is MPS, mucopolysaccharidosis. All points suggest it is MPS, mucopolysaccharidosis. Now, why it's Gaucher, Shahid? Mucopolysaccharidosis, it's Hurler. Short stature, फेस लग रहा है ये सिंड्रोमिक बच्चा है, हेपेटोस्प्लेनोमेगाली. Then comes the 2 points: large tongue, corneal clouding, copious nasal discharge. It is MPS. Hurler. So these are the MPS. Key MCQs. All are autosomal recessive. Only Hunter is X-linked recessive. Boys are always affected. Girls are carrier. Which mucopolysaccharidosis is X-linked recessive? It's Hunter. It's Hunter. Clear? No corneal clouding in Hunter and Sanfilippo. See here. MPS with no corneal clouding. MPS with no corneal clouding. Answer 2 and 3. Hunter and Sanfilippo. How to remember the name? No. Hurler, Hunter, Sanfilippo, Morique, Marotiox, Lemmy, Slee, and Netkovich. Remember once more. Pronounce one more. You will remember. Hurler, Hunter, Sanfilippo, Morique. Just remember. MPS with no corneal clouding. Hunter and Sanfilippo. 2 and 3rd. Now I want answer from your side. MPS with normal IQ. It's MPS rule. Child is mentally retarded. But 2 MPS, IQ is normal. MPS with normal IQ. Very good. Rebecca, Morique, good. No decades, not Hunter. MPS with normal IQ, type 4 and 6. Morique and Mero TX Lemmy. Remember, no corneal clouding, Hunter Sanfilippo. The person who hunt need a clear vision, na? No corneal clouding and Sanfilippo. MPS with normal IQ, MM IQ normal. Morique and Mero TX Lemmy. MPS with non-immune hydrops fetalis. MPS with non-immune hydrops fetalis. Come on, I want answer from you, Akshat. MPS with non-immune hydrops fetalis. Type 7, that is Slee. These all are MCQs, my friend. These all are must-know MCQs. Something more? Good. See here. Urine turn black when exposed to air. Give me the diagnosis. Mother tell, as soon as child passes urine, nappy turn black. Urine turn black when exposed to air. L-captonuria. L-captonuria. Now, DK, tell me which enzyme deficiency is there in L-captonuria? It is due to deficiency of homogentisic acid oxidase. Clear? So one feature is deficiency of homogentisic acid oxidase. Urine turn black when exposed to air. Second classical feature of L-captonuria, onchronosis, that is deposition of black pigment in various body tissue. Deposition of black pigment in various body tissue. Clear? Something more. Exaggerated startle response is a feature of Tay-Sachs disease, and it is due to deficiency of hexaminidase A. Now, I will hold here. I want answer from your side. Aminoacidopathy prone for thromboembolic episode. Stroke. Which aminoacidopathy leads to stroke? Aminoacidopathy prone for thromboembolic episode. Very good, Akshat. It is homocystinuria. Now, my second question. Homocystinuria responds to which vitamin? It is which vitamin dependent condition? Come on. Homocystinuria asked in the exam. It is B6 pyridoxine dependent condition. So my friend, these all are MCQs. MPS, L-captonuria, Tay-Sachs, homocystinuria. I'm not going in detail of theory because you know all the things now. Just to revise, these all are must know MCQs. Must know MCQs for your mission FMG. I am here with you. Angiokeratoma lipoma present in. Answer from your side. You put first letter, I will got the answer. Angiokeratoma lipoma present in. Angiokeratoma lipoma present in. Fabry's disease. Fabry's disease. Fabry's disease. No. It's Fabry's disease, and it is due to deficiency of alpha galactosidase. One more. Self-mutilation is a feature of. Come on. Yes, DK, Akshat, Yusuf. Self-mutilation, self-injurious behavior. Very good. It is a feature of Lesch-Nyhan syndrome. It's uric acid disorder. Uric acid disorder. Lesch-Nyhan syndrome. So my friend, these all are the must know topics. Must know MCQs. Answer this. Very good, DK. Now you are reading my mind. But I didn't ask. One Lesch-Nyhan syndrome is due to deficiency of which enzyme? HGPRT. Very good, DK. I like it. I like it. It is due to deficiency of. Sir, you are asking deficiency in all. You asking deficiency is this also. Lesch-Nyhan syndrome deficiency of HGPRT enzyme. Good, good, good. Six-month male present with failure to thrive, eczema, history of recurrent infection. Thrombocyte count 20,000. So what is this? It's a triad of TIE. TIE. T for thrombocytopenia, I for infection, E for eczema. It's a triad. It is Wiskott-Eldridge syndrome. It is X-linked recessive disorder. So present only in boys. In our question, 6-month-old male present with eczema, infection, thrombocytopenia. But one more thing here, peripheral smear revealed microthrombocytes. This is asked in one of the previous exam. Tiny platelets. Is a feature of Wiskott-Eldridge syndrome. Tiny platelets. It's a feature of Wiskott-Eldridge syndrome. And which immunoglobulins level low in Wiskott-Eldridge syndrome? Anybody? I told in my previous classes, eczema. So you can presume IgA and IgE remain to be elevated. Eczema is there, allergy is there. Okay. IgG will be normal. What is the spelling of Wiskott-Eldridge syndrome? It is W. You invert W, it becomes M. So IgM is decrease in Wiskott-Eldridge syndrome. Yes. Kalpu, Sandhya, M is decrease. IgM is decrease. So these all are MCQ about Wiskott-Eldridge syndrome. It is X-linked recessive, present only in boy. Ti is the triad. Thrombocytopenia, infection, eczema, tiny platelets, IgM decrease. Tell me any syndrome in which platelets are huge, dilated. Mega platelets is a feature of, come on, you know it, tiny platelet, Wiskott-Eldridge syndrome. Mega platelets, huge platelet, giant platelet is a feature of, it's a feature of, no, Bernard-Schuller syndrome. I will discuss in tomorrow's class. Bernard-Schuller syndrome, Bernard-Schuller syndrome, mega platelets. So this is again a evergreen image based question. Low platelet, absent radius, it's a TAR syndrome. You see, sub radius should be there, but radius is not there. Radius is not there. So what is this? Absent radius, it is TAR syndrome. Low platelet with eczema, it is Wiskott-Eldridge syndrome. Low platelet with hemangioma, patient has hemangioma on face, retroperitoneal hemangioma, it is Casa-Beck syndrome. I write here because it's obstructed with my image. Casa-Beck-Merritt syndrome. Casa-Beck-Merritt syndrome. Low platelet hemangioma, Casa-Beck-Merritt syndrome. Rahul, I have already have UPSC. I have a good recorded lecture on UPSC. You can check Unacademy platform and YouTube also. Casa-Beck-Merritt syndrome. So low platelets with associated finding, you should know. Now, you are going for a pediatric exam. You should know about marasmus and kwashiorkor. It will take just 2 minutes for marasmus and 2 minutes for kwashiorkor. 6 point, give a clear picture of marasmus. Weight less than 60% of expected. Suppose 1 year, weight is 10 kg. At 1 year, normal weight is 10 kg. At 1 year, if child weight is 5.5 kg, less than 60%, 10 kg 60% is 6. Weight less than 6%, less than 60% of expected, you think it's a marasmus. Mid-arm circumference less than 11.5. Mid-arm circumference less than 11.5. Severe wasting. Child appear thin. Body is made up of skin and bone. All fat disappear. Body is made up of skin and bone. Old little man appearance. Buccal pad of fat loss. See, these 4 points give you a clear imagination how marasmic it look like. You saw this picture on TV, African kids. You saw this live on bus stand, railway station, beggars. They are the classical marasmic kids. Fifth and sixth point will help you to solve the MCQs. Marasmus child is always irritable. MCQ you will find dull child. It's not dull. It is irritable child. Voracious appetite. They are very hungry. Then why they become marasmus? Because they have no food to eat because of poverty or some other reasons. They have voracious appetite. This is MCQ. Answer question will come. Anorexia. No anorexia is a feature of marasmus. Marasmic kid have voracious appetite and those are irritable child. Voracious appetite, irritable child. Marasmus. Kwashiorkor. They have essential and non-essential feature. Essential are must. You can't make the diagnosis of Kwashiorkor without these essential point. Number one, growth retardation. Weight between 60 to 80% of expected. If it is less than 60, it is marasmus. Less than 60 to 80% of expected. 1 year weight is 10 kg. If 1 year child weight is between 6 to 8 kg, we can call them Kwashiorkor if other 2 points are also there. What are other points? Edema and mental changes. Kwashiorkor child is dull, apathic, no interest in surrounding. Mental changes, dull, apathic, no interest in surrounding, doesn't play with the toy, and edema over body. These are the 7 kg child of 1 year having edema, dull child, you make the diagnosis of Kwashiorkor. These are essential. Few are non-essential, which is not required but may be present. Those are hair changes. On hair, you find flag sign. This is hair. You find alternate band of pigmented and depigmented hair. Flag sign. Skin changes. Flaky paint dermatosis. This is the word given. Skin hyperkeratotic patches. Not in all, but you may find in some. Hepatomegaly, MCQ. Present in Kwashiorkor, not in marasmus. Remember, fatty liver, anorexia, chillosis. My friend, these are very simple, but you need to remember. Can you trust me? This question at least 6-7 times in last 20 years. All are the feature of, in any exam, whether NEET, PG or FMG, all are the feature of marasmus except D choice was hepatomegaly. Hepatomegaly is not a feature of marasmus. Hepatomegaly is a feature of Kwashiorkor. Answer. Now answer this question. Kwashiorkor diagnosed in growth retarded child along with, you need other 2 points to make the diagnosis of Kwashiorkor because those are essential criteria. One is edema, other is mental change. Remember this. One is edema, another is mental change. Kwashiorkor diagnosed in a growth retarded children along with edema and mental changes. Answer this question. I wait for your response. You can answer this question. My goodness. No, it means you need this. I was thinking everybody put it right. Infant of diabetic mother, 30 to 34 week. It's a preterm. develop respiratory distress within 4 hours. This is the diagnosis of HMD. Number 1, preterm. Number 2, onset of respiratory distress within 6 hours. 2 points are there. Respiratory rate 80, grunting, duskiness, X-ray show, air bronchogram. Air bronchogram. Third point, abnormal X-ray. Air bronchogram. Preterm, distress within 6 hours, abnormal X-ray. What is this? Hyaline membrane disease. Some very good question on HMD. Revise in 2 minutes. Revise in 2 minutes. HMD. It is due to deficiency of surfactant. Surfactant is secreted in type 2 pneumocyte which keep the alveoli open. HMD is due to deficiency of surfactant, and surfactant produced in type 2 pneumocyte. It appear on lung surface 20 week MCQ. It appear in amniotic fluid 28 to 32 week, another MCQ. It mature at 35 week. Means any baby born before 35 week, risk of HMD is there. Now MCQ. Steroid and thyroxine increase the surfactant. Other side, insulin decrease the surfactant. In our question, infant of diabetic mother deliver at 30 to 34 week. In infant of diabetic mother, insulin is more in baby. So what insulin does? Decrease the surfactant. So remember, steroid and thyroxine increase the surfactant. Insulin decrease the surfactant. Some more MCQs. If mother is having diabetes, it's a risk factor. Why? This is mother. Mother is having diabetes. This is baby. So excessive glucose from mother goes to baby. Baby Langerhans is normal. So baby contain more insulin. And insulin decrease the surfactant. Risk for HMD. Other side, mother is having hypertension. If mother is having hypertension, in mother's body, circulating steroids are more. So delivery take place 32 week, but steroids are more, which take the surfactant level to 35 weeks. So mother is having hypertension, it is protective for HMD. Mother is having hypertension, it is protective for HMD. Clear? Clear? Some more. Diagnosis. How you diagnose HMD? Simplest, by chest X-ray. Chest X-ray. You find air bronchogram in mild form of HMD. Find reticular pattern in moderate form of HMD. Ground glass appearance in severe form of HMD, where all lungs are collapsed because of surfactant deficiency. Collapse. Ground glass appearance. Simplest way to diagnose with X-ray. Other thing. Check LS ratio. Lecithin sphingomyelin ratio. Normally it is more than 2:1. You are planning it cesarean at 34 week. You are obstetrician. You want not only take care of mother, but give healthy baby to the family. So 35 week, you are a little bit worried. Baby may develop HMD. Check LS ratio and amniotic fluid. If it is more than 2:1, no risk of HMD. Lungs are mature. LS ratio less than 1.5:1 indicate lung immaturity. Remember this. LS ratio less than 1.5. LS, lecithin sphingomyelin ratio less than 1.5:1, it indicate lung immaturity. Shake test. Shake test negative. What is shake test? Now you get X-ray in 1 minute. With good X-ray machine, as soon as they take the X-ray, You can watch X-ray on their monitor in a second. But in our days, when radiographer came to the nursery, they took X-ray, then they take X-ray with them. Dark room where films are dried. It take lot of time. So meanwhile, we do a shake test. We take a test tube and put gastric aspirate in it, 2 ml, and 2 ml alcohol in this. And we shake. When we shake, you shake the liquid, rim of bubbles is forming. Bubbles rim form means lungs are mature. You are shaking, shaking, shaking. No bubbles are forming. Shake test negative. Shake test negative denote lungs are immature. Lungs are immature. So this was the question. Shake test used to assess maturity of brain, heart, lung, gut. Lung. Negative shake test. No bubbles are forming. What it indicate? Lungs are immature. Lungs are immature. These all finds about HMD. It is due to deficiency of surfactant, which produce in type 2 pneumocyte. Surfactant appear on lung surface at 20 week. In amniotic fluid 28 to 32 week. Mature at 35 weeks. Clear? Hypertension, protective against HMD. Infant of diabetic mother, risk for HMD. Diagnosed by chest X-ray, LS ratio or shake test. Question will be there on HMD. Clear? Clear? Few point you must know. Lot of questions are there. If mother taking lithium during pregnancy, Epstein anomaly of heart occur. If mother is having SLE, congenital complete heart block occur in the baby. If mother is having mumps during pregnancy, this is a question asked in most of the neonatal quiz, MD level or MBBS level. Mother develop mumps during pregnancy. What anomaly occur in baby? Endomyocardial fibroelastosis, EMF. AIMS 2020 question. Mother is taking carbimazole, methimazole, antithyroid drug. What anomaly occur in the baby? Aplasia cutis congenita, which is scalp defect. Scalp defect. Mother is taking erythromycin during pregnancy. Pyloric stenosis. And this is your last year FMG question. Mother is taking sodium valproate. What occur in baby? Neural tube defect. Neural tube defect. Yes, Nirmala, there are so many MCQ on Epstein, box-shaped heart. I will discuss tomorrow when I discuss systemic pediatrics. So remember these points. I will be glad if we have direct question from this slide. Clear? Because 3-4 times questions are there in exam, but your level is now above than that. Epstein anomaly, mother is taking lithium. That was old question. It still can come. Mumps, aplasia cutis congenita, neural tube defect. These are the current topics. Answer. Last year FMG, 5-year-old develop fever with rash. When fever with rash, only one thing comes in the mind, measles. See, also had cough, conjunctivitis, chorea. 3C. Image of the child given below. That was there, but I didn't put the image here. 3C, fever with rash. It is measles. Measles, the classical rash appear on 4th day of fever. When rash appear, fever increase. Classical history. Now measles is rare because of vaccination. In our MD days, so many kids comes with measles. Whole class develop measles. Whole family develop measles. Classical history. Initially, running nose, fever. Mild fever, 3-4 days. Parents come on the 4th day. Doctor, see, today all body rash is there and fever is 103 today. 4th day rash. When rash appear, fever shoot. Roseola infantum, also known as 6th disease, caused by human herpes virus type 6. This also rash appear on 4th day. But the classical point of roseola infantum, as rash appear, temperature returns to normal. Temperature returns to normal. So this point you remember when you have a history based question on measles or roseola infantum 6th disease. You always remember this point. You always remember this point. Okay. Rash on 4th day, fever shoot, it measles. Rash on 4th day, temperature comes to normal, it is roseola infantum. Roseola infantum. Answer this. Weakness started in lower limbs, gradually progress upward and involve trunk. It is ascending paralysis. First lower limb, then upper limb. DTR absent, hypotonic limb, ascending paralysis. So what is this? This is GBS, Guillain-Barré syndrome. The classical CSF finding of GBS: cells normal, only protein increase. The word used for it, albumino, cytological dissociation. Only L protein increase, not cell, not cell. I will try to make some difficult question. Don't worry. These are the common question which was asked and supposed to be asked. Difficult is coming. Hold on. According to neonatal resuscitation protocol, chest compression is initiated at heart rate below. Newborn is there, gasping, no respiration. You started bag mask ventilation. Okay, after doing bag mask ventilation for 15 seconds, you assess the heart rate. If heart rate is more than 60, continue. But if heart rate is less than 60 per minute, what you do? You start chest compression. So chest compression is started when heart rate is less than 60. Now answer my question. You started chest compression. What is the ratio of chest compression to ventilation in a neonate? 3:1. 1, 2, 3, 1. 1, 2, 3, 1. 1, 2, 3, 1. 1, 2, 3, 1. Ratio is 3:1. Once you started chest compression, then you have a curiosity in mind. Now I will see what is the heart rate. So after how many seconds? When you started chest compression, after how many seconds? Once you started chest compression, after how many seconds? You will again assess the heart rate. No, it is after 60 seconds. After, no, it's not 2 minutes. After 60 seconds. Previous guideline tell it's 30 seconds. Newer guideline say after 60 seconds. Once you start chest compression, you need to assess heart rate again after 60 seconds. Clear? This is about chest compression. When you start, when less than 60. What is the ratio? 3:1. Once you started, when you assess the heart rate again after 60 seconds. If it is more than 60, stop. Less than 60. Then what you will do? Continue chest compression. After 60 seconds, you again assess. It's dipping. It's not picking. Think about adrenaline. What is the dose for adrenaline? Adrenaline is given 1 is to 10,000 dilution. Dose is 0.2 ml per kg. This is as per newer guidelines. ADR 1 is to 10,000 dilution. Dose is 0.2 ml per kg. Per kg. Per kg. 0.2 ml per kg. Answer this question. Bilateral cataract, IUGR, hemorrhagic skin scattered lesions. These are known as blueberry muffin lesions. Blueberry muffin lesion. Systolic murmur heard over left sternal border. What is this? This is rubella syndrome. So you are going for exam. Torch group of infection you can't avoid. So we learn one by one. What is triad of rubella? Deafness, cataract, CHD. Which CHD? PDA and PS. Now, triad of toxo. Chororetinitis, diffuse cerebral calcification, hydrocephalus. CMV, congenital varicella syndrome. Limb hypoplasia is a classical feature. Cerebellar hypoplasia, another classical feature. We will do the MCQs. Limb hypoplasia, finger, limbs not there. Congenital varicella syndrome. And CMV, periventricular calcification. Periventricular calcification. These all are old, traditional, coming so many times. This is newer. Parvovirus. If mother develop parvovirus infection, baby will have non-immune hydrops fetalis. If mother is having HIV during pregnancy, severe thrush, failure to thrive, calcification of basal ganglia occur in baby. Zika virus infection, Zika virus, baby will have microcephaly, lysencephaly, cerebellar hypoplasia, subcortical calcification, and ocular findings. Lysencephaly, remember this word, not in India, but Zika virus infection is there. Okay, so mother is having Zika virus infection, baby will have lysencephaly. Lysencephaly means smooth brain. Normally, brain is like this. Here, brain is smooth. Brain is smooth. Lysencephaly. So these all are Trach group of infection, and you should be know all of them. See, now the question is very simple. Neonate with rudimentary digits, cortical atrophy, cerebellar hypoplasia. Rudimentary digit means limb hypoplasia. Limb hypoplasia, rudimentary digit. Answer it, chickenpox embryopathy. You did two toughest question. Question are there. Diffuse cerebral calcification is feature of toxoplasmosis. Periventricular calcification is feature of CMV. This type of question is there in exam. These two are the toughest which you did. This is rubella. Remember the feature of rubella, toxo, varicella, CMV. And in detail, mother is having parvovirus, mother is having HIV, mother is having Zika virus infection. What anomaly occur in the baby? And this is the question. Answer. Vitamin A deficiency treatment is vitamin A. Dose depend upon age less than 6 months, 6 to 12 months, more than 12 months. Less than 6 months, 50,000. 6 to 12 months, 1 lakh. More than 12 months, 2 lakh. One dose today, one next day, one 4 week later. So they are asking 8-month-old child, means between 6 to 12 months. So what will be the dose? 1 lakh. 1 lakh. Simple. Simple. Answer. Evergreen question. A full-term newborn baby having episode of cyanosis which increase when child is attempt to feed, and cyanosis decrease when child is crying. Cyanotic heart disease, cyanosis increase when child is crying, but here cyanosis decrease. So B is not there, C is not there. Cyanosis increase when you feed the child, nostril are closed, corneal atresia, when you feed the child, from where respiration. Cyanosis increase while feeding is classical of corneal atresia. Corneal atresia. Simplest. Answer this question. Answer this question. 18-year male child presented with complaint of delayed onset of puberty. This is the commonest presentation. But when you examine, child is tall, underweight, large arm span, and small testis. Child is having history of antisocial behavior during school days. So what is the most probable diagnosis? Akshit, Pandey, future doctor. Yes, it is Klinefelter syndrome. They present most of the time with delayed onset of puberty, but can be suspected in a childhood if child is very antisocial behavior. 10 fifth 10-year-old child reading in 5th standard, मार दूंगा, काट दूंगा, जला दूंगा, very aggressive, not appropriate for his age, antisocial behavior, then also you suspect. Otherwise they suspected, diagnosed during delayed onset of puberty. Klinefelter 47XXY, 1X is extra. Two good MCQs. They are prone for breast cancer and varicose vein. They are prone for breast cancer and varicose vein. Now answer this question. 10-year-old female presented with short stature, webbing of neck, cubitus valgus. Oh, it's Turner syndrome. Next question. Hold on. Read whole question. Her chromosome study shows normal karyotype. What is the karyotype in Turner 45X0? It's not normal karyotype. So answer can't be Turner. Feature of Turner, but karyotype normal. It's Noonan syndrome, and it's a commonest mistake. Last year NEET PG 2 question from Turner syndrome. Why not this year for you FMG? Yes. These feature karyotype normal means it's a Noonan syndrome. It's a Noonan syndrome. It's not Turner. Remember, again read this question. Feature of Turner, but karyotype normal. Normal karyotype. It is Noonan. Answer. Look at the picture. 18-month presented to you, complain of bleeding gum, not moving his limbs, pseudo paralysis, delayed wound healing, all are the feature of scurvy. But they give you X-ray. What is the most prominent feature in X-ray? You will see here this ring-shaped epiphysis. Very visible, clearly visible, ring-shaped epiphysis, and this is white line of Frankel which extend below the shaft. This is main Pulcan spur. These are the classical. Frankel line, there is a black line of scurvy. Hold on, I will give you everything. This is the schematic picture. Ring-shaped epiphysis, Wimberger sign. white line of Frankel. If it extend beyond the shaft, it's Pulcan spur. Subperiosteal bleed, black line of scurvy. This is the classical X-ray of scurvy. You can't miss this X-ray if you are going for any competitive exam, my dear friends. Scurvy X-ray. Wimberger ring, line of Frankel, Pulcan spur, black line of scurvy, subperiosteal bleed. These all are the classical feature of scurvy. Now I am coming just 5-6 question remaining, but those are lifetime memorable images. Be there. Answer this. Child can able to make figure A. What is figure A? Child can able to make figure A means plus. Child can able to make plus sign by 4 years. This is cross sign. Child can able to make cross sign by 5 years. Question is there. Child can able to make figure A but not figure B. So age of the child is, यार अब तो आंसर लिख दो. Age of the child is, child can able to make plus but not the cross. Age of the child is 4 to 5 years. Child can able to do work of a 4 year of age but not 5 year of age. So what is the age of the child? Between 4 to 5 year. Clear? Answer this. Child can able to make tower of how many cubes? This is 1 cubes. This is second cube. This is third cube. Child can able to make tower of 2 cubes at 15 months. 3 cubes at 18 months. 6 cube at 24 months. 9 cubes at 36 months. 9 cubes at 36 months. So 3 cubes child can make 18 months of age. Why, Nirmala, you are answering A? Yes. Why, Pandey, you are answering A? 3 cubes 18 month. 3 cubes 18 month. Clear na? Clear? Answer. I want answer from your side. Whether it's Rafiq, Rebecca, Morgan, Faraz, Akshit, Humble, Nirmala, Pandey, I want answer from your side in this question. See the ECG. This is R. This is R. This is R. This is R. 2 RR. 1 large square, second large square, third large square, fourth large square, fifth large square, sixth large square. So 300 divided by 6, heart rate is 50. Any newborn with 50 heart rate in which you are seeing more P than R. More P than R. P are more than R. It is complete heart block. When a neonate heart rate is 50, first thing come in our mind, mother is having SLE. How can we prove? Maternal serum anti-Rho and La antibody. Anti-Rho and La antibody. Maternal serum anti-Rho and La antibody. Clear? First, you need to identify from the pic, it's a complete heart block. Then what test you want to do in mother? Anti-Rho and La antibodies. Haha, beautiful question. Answer this. Milestone shown in pic achieved by what year of age? Anybody put in the comment box what milestone is this? What milestone is this? Anybody put in the comment box? No, I don't want ABC. What milestone is this? This is creeping. Creeping. Very good, Rebecca. This is creeping. Where chest is above the floor. Creeping comes at 10 months. Another word is crawling. Crawling come at 9 months. How you remember? Spelling of crawling, C-R-A. C-R-A. Spelling of creeping, C-R-E. A comes first, so crawling comes first, 9 months. Creeping, 10 months. What is the difference between crawling and creeping? Here you see. This is crawling. And this is creeping. Crawling, chest touches the floor. Creeping, chest above the floor. Chest above the floor. This is crawling. Crawling come at 9 months. This is creeping. Creeping comes at 10 months. Am I clear? Now, these two pictures, girl is jumping, girl is jumping. What is the difference? Here, jump with one leg. This is hopping. Jump with both leg. This is skipping. Hopping come at 4 years. Skipping come at 5 years. Okay, honored. If you gain something from the class, crawling when the front touches the floor, creeping front above the floor. Hopping, jump on one leg, skipping, jump on both legs. Hopping come at 4 years, skipping come at 5 years. So yeah, this is the class. With my experience, these are the questions. So you will prepare and your morale will be high. Answer. This condition of nail present in, what is the condition? Spooning of nail. We also call it cholinakia. This is present in iron deficiency anemia. Iron deficiency anemia. Arsenic poisoning, you have Mees line. Liver failure, you have Terry line. Kawasaki disease, Bew line. Forget, this will not come. But yes, spooning of nail, cholinakia is classical of iron deficiency anemia. Answer this question. Full term, neonate, present 4 hours after birth with respiratory distress. X-ray given suggestive of, yes, these are the bowel loops. Herniation of intestine through foramen of Bok-Delek into thoracic cavity. It is congenital diaphragmatic hernia. What happened? Apex beat or heart shifted to the right side. Heart, apex beat shifted to the right side. Apex beat or heart shifted to the right side. When intestine comes in the thoracic cavity, what will happen? Abdomen is scaphoid shape. Abdomen is scaphoid shape. Clear? So yeah, a child presented with distress few hours after birth. On examination, apex beat on the right side. X-ray show air fluid level in the thoracic cavity. Abdomen is scaphoid shape. These all indicate it's a classical history of diaphragmatic hernia. One MCQ will remember, bag, mask, ventilation is contraindicated in diaphragmatic hernia. Bag, mask, ventilation is contraindicated in diaphragmatic hernia. So today's class, what we cover, few good images, vaccine, milestone, syndromes, metabolic diseases, infection, measles, all these questions. Basically, question from general pediatrics. General pediatrics. Systemic pediatrics, yes, it's remaining. Question from glomerulonephritis, Alport syndrome, Berger disease, TAPVC, TGA, all those questions, neurology, endocrinology, systemic pediatrics, question on epiglottitis, croup, question on asthma, systemic pediatrics. Learn systemic pediatrics with me, Dr. Sanjay Khatri. Tomorrow, same time, 8 p.m. Yes, I try to give you good concept of questions for your FMG in class FMG Mission 150. I try to give you those questions which are probable, must know questions from my side in systemic pediatrics. Today we cover the basic pediatrics in which vaccines, milestone, those basic questions. Systemic pediatrics class अभी बाकी है दोस्त. Tomorrow, yes, I will thrill you with some good systemic pediatrics question. So wait tomorrow. I request you to join me tomorrow at 8 p.m. to learn systemic pediatrics. Most important question for mission FMG, your FMG exam. So be cool and relax. Keep reading, keep reading, keep reading. That's all. With good sense of well-being. Keep your morale high. Nothing to lose. Just read, read, read and relax. Okay. Thank you. Bye bye. Hope to see you all tomorrow at sharp 8 p.m. God bless you.